Good afternoon, everyone. My name is Deborah Levine, and I am the director of the Harlem Health Initiative for the SUNY School of Public Health and Health Policy. It gives me great pleasure this afternoon to bring to you the beginning of our fall skills building webinar series. For us this year, it is all about COVID and the intersection of the work that we do. I am going to decrease so that I can allow Dr. Tisdale to begin the presentation today. We will be going for about an hour. Please know that we'll ask people to stay on mute. And use the chat function if you would like to ask a question. This presentation is being recorded. It is also on Facebook Live on the Harlem Health Initiative Facebook page, and it will be cataloged in our YouTube channel, and we'll be happy to send out that link when it's finished. And we will also send out the link for this recording shortly after this event ends. I'd also like to share with you that we are doing this in collaboration with the New York Literacy Vaccine Project here at the school. So I welcome my colleagues there also. So thank you very much. And Dr. Tisdale, take it away.
Okay, I'm letting in a lot of people from the waiting room. Just you guys will take that.
I got it.
Yeah, great. Okay. Well, thanks everyone. Thanks for joining today. I'm just going to share my screen. Okay, so thank you, Deborah, and thank you to the Harlem Health Initiative for inviting us to present today, and thanks to all of you again for attending. I'm Chloe Teasdale. I'm an assistant professor in the Department of Epidemiology and Biostatistics here at the CUNY School of Public Health. My work focuses on the health of children and adolescents and pregnant women in the US and globally. I'm joined today by my co-presenter, Dr. Medhura Rain, who will introduce herself.
Hi, everyone. I am Madhura Rane. I'm a postdoctoral research fellow at CUNY with Professor Dennis Nash. I am an infectious disease epidemiologist, and my work focuses on how diseases spread in space and time, analyzing vaccine effectiveness studies and vaccine hesitancy. And thank you so much for the opportunity to present here today.
Great. So today we're going to be talking about COVID-19 vaccines for children and parental acceptability in the US and in New York City. I'm going to start by giving an overview of pediatric COVID-19, the epidemiology in the US and New York City. And then Dr. Rainey is going to give some information about COVID-19 vaccines and trials in children. I'll then present some findings from surveys that we conducted in the US and in New York City around parental vaccine acceptability and hesitancy. And then we'll end with discussion around vaccine hesitancy prior to COVID-19 and how the COVID-19 vaccines for children fit into that picture, and then hope to have a discussion with all of you about these issues. So since the start of the epidemic in the US in early 2020, more than 6 million children less than 18 years have been diagnosed with COVID-19. So I want to make that point that these data are about children who've been diagnosed, so children who were taken for testing and tested positive. And I'll mention that a little more when we talk later about New York City data. So children represent only about 16% of all cases in the US since the start of the epidemic. You can see that in the figure on the bottom, which comes from the CDC. So children 0 to 4, 5 to 11, and 12 to 15 are the yellow lines. And you can see that they track very closely the trends in adults, but the case rates were much lower in children for the first 15 or so months of the epidemic, including the increase, the surge last winter that we experienced in the US. Starting over the last couple of months, so around July of 2021, we've seen a significant increase in the proportion of all US cases that are in children. So we would expect that based on the fact that many adults are now vaccinated. So we expected to see an increasing proportion of cases among children. What's really concerning, though, is that there's also been a significant increase in the absolute number of cases in children, and this has gone up quite dramatically as a function of the fact that, the emergence of the Delta variant, right, which is highly contagious, and because of reopening, including the start of the 2021-2022 school year. So you can see here, starting around July and August and September, that we see the numbers, the proportions of cases among children and the number of cases among children going up very rapidly. Fortunately, COVID-19 cases in the US are going down overall. Many parts of the US are still experiencing very high numbers of cases among children. This is almost exclusively in states that have low vaccination coverage in adults. I'm sure many of you have read the reports and seen news reports about, pediatric ICUs being full in some states, many schools having to close because of continued community transmission and transmission in kids. So this remains, so infections in children remain a significant issue. What do we know about COVID-19 infection in children? So there's still a lot we don't know. And there's ongoing debate about whether children are at less risk of acquiring COVID-19 infection and what role they play in transmission. But we do know that children are less likely to have symptoms and severe disease when they're infected with COVID-19. So we've had about 5,200 cases of multisystem inflammatory syndrome in children, which is a very serious complication of COVID-19 infection, but luckily has been quite rare. It causes inflammation of different organs, including the heart and the brain and the lungs. And there have been 46 deaths that have been attributed to MIS-C. But overall, most children tend to have fewer symptoms and less severe disease compared to adults. Unfortunately, though, we're also seeing that children are developing long COVID. So this was first identified in adults, and it's a complication where people have ongoing symptoms of COVID-19. In children, it tends to be fatigue and pain and heart palpitations, and these are going on for months for many children, including children who had no symptoms at the time of their COVID-19 infection. And the data available now suggests that about 13% of children with known COVID-19 infection are experiencing long COVID. So this is a large number of children when you think about 6 million children having been infected. A big question mark is about whether and what the long-term health effects of COVID-19 infection in children may be. We know from other viral infections that there can be ongoing impact over the life course. So infections that are experienced early in childhood or at different points in childhood can cause long-term health effects. And so there are ongoing longitudinal studies that are looking at what the long-term effects of COVID-19 infection in children may be. Getting a little more local, these are data from New York City. So this is pivoting from the national picture to our more local setting in New York City. And this is a slightly difficult figure to read, but this on the right is showing the number of cases per 100,000 children in the US in states in the US, and then New York City is also included and compared to the other states. And what we can see is that despite being the early epicenter, right, New York City was the hardest hit early in the epidemic in the US, we've had relatively few infections among children compared to most other states in the United States. So there have been about 109,000 children diagnosed and 29 deaths in New York City in the 5 boroughs. Children represent 12% of all diagnosed cases in New York City and less than 1% of deaths. I want to make a note, however, that again, to go back to what I said earlier, that these data on cases of COVID-19 in children are only for children who are tested and diagnosed. And as I also mentioned earlier, many children don't have symptoms from COVID-19. So it's possible that we've really undercounted and we've underestimated the number of children who have experienced COVID-19 infection. And using data that were conducted by Dr. Rain and others at the Institute for Implementation Science in Population Health here at the CUNY School of Public Health, they looked at data from CityMed, the urgent care centers in New York City, and they looked at serologic testing for COVID-19, and that can identify a past infection or a current infection. And they found that of all age groups, 5 to 14-year-olds had the highest indication of either a previous or current infection with COVID-19. So these data really suggest that many children in New York City may have been infected with COVID-19, but were not tested and therefore were not counted. And this may be due to lack of symptoms. There wasn't a need to test them, or they had limited access to testing. If you remember, access to testing was quite challenging early in the epidemic, and so that may have impacted our ability to accurately know how many children were infected with COVID-19. And so I just want to share these data as well. If you're a New York City parent with a child in the school system, you may be familiar with this website. This is the New York City Department of Education's COVID case map, which they put out every day to show you where schools have cases, where classrooms have been quarantined, where entire schools have been shut down. And so even though we're doing a great job in New York in many ways, and we have reached we haven't gotten where we need to be with vaccination in adults, but we're very close, and we're vaccinating teenagers, and we're doing a good job with not having a lot of kids infected. We still have a lot of impact on the lives of children from COVID-19, both directly from infections and also from disruption to education. So since the beginning of the school year on September 13th, there have been almost 4,000 COVID-19 cases identified among students in New York City schools and 1,300 in staff. So fortunately, there aren't a lot of schools from this map. You can see, if you can read this guide here, there aren't very many entire schools that are closed, but there are lots of classrooms that are currently where kids are having to quarantine. So lots of work still left to do in terms of controlling the COVID-19 epidemic in children. I also want to make an important note about the racial and ethnic disparities that have been so evident in this epidemic among adults, and to note that this is sadly also true for children. So these data are cumulative cases since the start of the epidemic. And so you can see that among, this is Native American children, and we also see among Hispanic children and children who are native to Hawaii, that they have much higher case rates compared to white and Black children. Although these data are, as I said, cumulative since the start of the epidemic, these racial and ethnic disparities were far more pronounced early in the epidemic. The recent surge among children has affected more white children. And so we see some of the numbers, those numbers coming up there. But these are, quite concerning numbers. And then when we look at mortality in children, this is deaths among children in the US less than 18 years by race and ethnicity since January 2020. We see very, very different patterns, right? We see that children, indigenous children, meaning Native American, Native Hawaiian children, have much higher risk of mortality from COVID-19 compared to Asian and white children. we want to, these data are really disturbing. And I would quote Dr. Clive Yancey, who very early in the COVID-19 epidemic in April 2020 noted that social distancing is really a privilege. And social distancing, as you all remember, was one of the ways we could protect our children and we could protect each other. But it really was a privilege, and it was a privilege that was not evenly distributed in our society, as is true of so many things. But I think focusing on these disparities is really important as we move forward in trying to make sure that we are protecting kids with all of the resources that we have. Okay, so that was just a very brief snapshot of the epidemiology in children of the epidemic. And now I'm going to turn it over to Dr. Ring to present the pediatric vaccine trial information.
Great, thanks, Chloe. So can we go on to the next slide? Okay, great. So currently there are 3 FDA-approved COVID-19 vaccines for US adults, Pfizer and Moderna, which are the messenger RNA or the mRNA vaccines, and the J&J or the Johnson & Johnson vaccines, which is a single-dose viral vector vaccine. Now, the COVID-19 mRNA vaccines are the first mRNA vaccines licensed for use. So the public approached them with a certain degree of caution. However, mRNA technology for vaccines is not new at all. Clinical trials for mRNA-based vaccines have been going on for decades. And the first mRNA vaccine ever tested was in the 1990s for influenza. So they've been around a while. Since then, several mRNA vaccine candidates against HIV, rabies, Zika have undergone clinical trials, and there are several vaccines against certain type of cancers that are also undergoing trials. So it's really a very promising technology. Next slide, please. So let's take a closer look at how these mRNA vaccines work. Coronavirus has something called spike proteins on its outer surface. Our bodies can actually identify these spike proteins as foreign and can make antibodies against them. So they are an ideal target for vaccines. So when you make an mRNA vaccine, you first take the messenger RNA from the virus, so mRNA is the genetic material that makes these proteins. We purify them and create a vaccine, which is essentially the mRNA wrapped up in a coating that makes it easy to deliver the vaccine to our bodies in a stable form. It is important to remember that the vaccine does not contain the virus itself. So we cannot get COVID-19 infection from the vaccine. Once we are vaccinated, stage 3 on this infograph, once we are vaccinated, the mRNA can enter human cells and teach the human cells to produce these spike proteins, which were found on the virus. But this time, this protein is expressed on the human cell. The mRNA does not alter our DNA in any way when it does this. The spike proteins are recognized by the body's immune system as shown in stage 5. And our immune system is triggered into generating a coronavirus-specific antibody response. So the next time you get exposed to the coronavirus, the antibodies that are now ready can bind to the virus and neutralize it, preventing disease. As for the mRNA in the human cells, once the mRNA delivers the instructions to make the protein, the cell just degrades it. Next slide, please. Viral vector vaccines, which is the J&J vaccines, work a little bit differently. They use a modified version of the virus that is not the coronavirus. It's a different type of virus to actually deliver the genetic material to a cell to create the spike protein. This genetic material that creates the spike protein is removed from the coronavirus, as shown in stage 1, and it is inserted into an unrelated inactive virus. In the case of the J&J coronavirus vaccine, this unrelated virus is a stable human adenovirus, which does not cause any disease in humans. So it's perfectly safe. Then they create a stable vaccine. It is delivered to humans. The harmless virus enters the human cell. Your cell reads and interprets the spike protein RNA and expresses the spike protein on the surface. The rest is the same. Like the mRNA vaccine, your body creates antibodies against the spike protein and protects against future infections. Next slide, please. So now that we understand the basic biology behind the vaccines, I'll talk a little bit about how the clinical trials are conducted with a focus on pediatric COVID-19 trials. Traditionally, it takes about 10 to 15 years for a vaccine to go from inception to production. There are 3 phases of clinical trials. Phase 1 is conducted on a small group of people, typically less than 100, and investigates vaccine safety and safe dosages for humans. Phase 2 has fewer than 100 participants. It runs a little long, has a little bit more than 100 participants, runs a little bit longer than safety studies, and investigates safety at a selected dose, for instance, and looks for signs of efficacy, which is production of antibodies against the virus. Phase 3 has several thousand people recruited, has longer follow-up periods going up to a few years, and investigates both safety and the efficacy of the vaccine, usually against a placebo or different doses of the vaccine. All of this data is presented to the FDA for regulatory approval, and when approved, the vaccine is manufactured. But for COVID-19, given that we were in the middle of a public health emergency, this process was contracted. We had to complete it quickly, and it was completed in a couple of years. However, no step was missed in the approval. The stages just happened, they just overlapped with each other. Next slide, please. All COVID-19 vaccines have been emergency use authorized. What does that mean? Now, essentially, FDA can grant an EUA or an emergency use authorization for a vaccine if it is deemed safe based on data from phases 1 and 2. If there is sufficient follow-up period in phase 3 to measure adverse events, infections, etc., and there are sufficient number of people in the trial. Also, the participants have to be actively followed up. So in case of coronavirus vaccine, because we were in the middle of this public health emergency, which was life-threatening, with a life-threatening disease, and there were no other options available, COVID-19 vaccines were right for emergency use authorization. Next slide, please. So to summarize, quickly compare FDA full approval versus emergency use authorization. In emergency use authorization, the production of the vaccine goes hand in hand with testing. Going back to the diagram, the CDC infographic which we showed where the phases overlap with each other, this is what it means, where the testing and the production are going hand in hand. Once approved based on sufficient data, the vaccine is ready for distribution with no waiting period for production. This time saved is crucial during a public health emergency, resulting in several lives saved. In contrast, for a full approval, the production happens only after approval, which adds precious months to the timeline until the vaccine is finally available to us. However, eventually, all the emergency use COVID-19 vaccines will receive full FDA approval. And the Pfizer vaccine for adults has already received full approval after EUA. Next slide, please. Especially for children, COVID-19 vaccine trials were focused on safety because we knew that the vaccine elicited a good immune response in adults. So the primary endpoints for most pediatric trials were local and systemic adverse reactions immediately after the vaccine, adverse reactions after 60 days, and serious adverse reactions such as multisystem inflammatory syndrome for up to a year after they received the vaccine. Then secondary to safety, seroconversion rate and antibody titers for a given dose are measured. But these are usually secondary endpoints because we know the vaccines elicit a good immune response as seen in adults, and we don't expect them to behave very differently in children with respect to eliciting an immune response. Next slide, please. So there are currently a few COVID-19 vaccine trials ongoing in children. We have the Moderna Teen Cove study and the Kids Cove study. The Teen Cove study is testing vaccines in children aged 12 years and older. And the Kids Cove study is for children aged 6 months to 11 years. Pfizer has 3 ongoing clinical trials for children for the COVID-19 vaccine in children. One has been completed in July 2021. The vaccine was authorized for emergency use for children 12 years and older, and there's one ongoing trial which is due to complete in April 23. They also have a phase 1, 2, 3 trial, which means that all phases of the trial are ongoing at the same time, which is testing multiple dosages for different age groups going from 6 months to 30 years. So this trial includes very young children and like going up to young adults. Next slide, please. So media recently reported that Pfizer is proposing EUA for their vaccine for children 5 to 12 years old. And this is coming out of early trial results from one of the trials I talked about in the previous slide. They have seen favorable results for a reduced dose vaccine among children, especially a very encouraging safety profile. The results are not available to the public yet, I believe, but the FDA is meeting next week to consider the evidence, and then CDC in early November. For younger children, things are a little less definite. Pfizer mentioned in July this year that a vaccine for younger age groups going up to from 6 to 5-year-olds will follow immediately after 5 to 12-year-olds. And hopefully we hear some good news by the end of the year. Next slide. Oh, that's all for me, Chloe.
Okay, and we just wanted to end this section with noting vaccine uptake for children who already have approval to receive the vaccine. So as Madhura noted, vaccines were approved this summer or late spring for children 12 to 17 years. And unfortunately, we haven't seen as much uptake as we would like to see. As of this week, only less than half of 12 to 15-year-olds have been vaccinated in the US, and 54% of 16 to 17-year-olds have been vaccinated. That's overall in the US. And we also see significant differences in terms of the states where people live. This maps, fairly closely to adult vaccination coverage in these states as well. We also see a breakdown by race and ethnicity here. And again, the trends suggesting that there are differences. So young teenagers and adolescents who are African-American are less likely to have been vaccinated in most of these states and overall. And we also see lower rates in some cases, in some areas also white children are less likely to have been vaccinated than other groups. So lots to be done for this group who already has approval to receive the vaccines. Somehow. Okay. Now I'm going to present some data from our survey that we conducted earlier this year. So this was a survey conducted by the Institute for Implementation Science and Population Health here at the CUNY School of Public Health. We launched this online survey in March of 2021. It was a cross-sectional survey, meaning we only conducted it once. We recruited parents and caregivers, specifically of younger children. So we wanted parents of kids less than 12 years of age. We ended up with just over 2,000 US parents, that's across all 50 states, and around 1,100 New York City parents in the 5 boroughs. Recruitment was quota-based sampling, so we were trying to match the characteristics of the population of parents and caregivers of children less than 12 in these 2 different areas. And the study received ethics approval from the Institutional Review Board at CUNY. For the survey, we asked parents, this was the question, when a vaccine to prevent COVID-19 is approved for children, would you want your child to receive the vaccine? And this question was specifically asked about the youngest child in the home, again, trying to oversample younger children. And parents could respond yes, no, or that they were unsure. So parents who said that they were no or unsure were considered vaccine hesitant. And those parents were asked the reasons why they didn't want to vaccinate their child. Parents were also asked about their own vaccination status. So this was in March of 2021. So vaccines had been approved for a month or 2, but many parents, so we asked both about whether they actually had been vaccinated or whether they planned to, versus parents who said they were unsure or were definitely not going to get vaccinated. These are our statistical methods. We compared characteristics using Rao-adjusted Pearson chi-square test. We used regression models to identify the characteristics of parents who were vaccine hesitant. And all of the analyses were adjusted for survey weights. So again, to get prevalence estimates or estimates for these 2 different populations, US parents and New York City parents. These are the characteristics of our survey. The median age of the youngest child in the household was around 5 years. You can see that most kids in the survey, about 92%, had some form of health insurance that paid for at least some of doctor visits. We can see that about half of kids were attending either school or daycare at least 1 day a week. Again, this is back in March of 2021. And we also see that the parent characteristics, particularly the race and ethnicity groups, are very closely aligned with the populations that these groups were representing. This is what we found. So when we asked parents whether they planned to vaccinate their children for COVID-19 when a vaccine was approved back in March of 2021, we found that about half of parents in the US, 49%, said they did want to vaccinate their youngest child. 25% were unsure, and 26% said no, they would not. In New York City, we found the rate to be higher. So 62% of parents said yes, they did plan to vaccinate their younger child. 23% were unsure, so that's really similar to the US, and then only 15% said they would not vaccinate. When we asked those vaccine hesitant parents about why they didn't want to vaccinate their children or if they were unsure, most said that it was because of safety and effectiveness. But a quarter also said that they didn't think that children needed to be vaccinated, that children are at low risk and there's no need to vaccinate them. Very few cited medical reasons or religious or philosophical reasons for not wanting to vaccinate. So it was primarily about safety and also the perception that children don't need it. We did in New York City observe some differences in these reasons for not wanting to vaccinate. So specifically the question about safety and effectiveness, we found that Hispanic and Black and Asian parents were much more likely to report this as their main concern compared to white parents. When we looked at the characteristics of which parents were vaccine hesitant in our survey, we found that female caregivers were more vaccine hesitant. So moms and other female caregivers of children in the US were more likely to say they didn't want to vaccinate their children. Parents of children who were not attending school were also more vaccine hesitant. In the US, Asian parents were less vaccine hesitant, so they were more likely to say they planned to vaccinate their children. In New York City, non-Hispanic Black parents were more vaccine hesitant, though, as compared to whites. Parents with less education and less income were also more likely to be vaccine hesitant. This slide may be a little confusing at first, but this was looking at the parents' vaccine status and then comparing that to what they said about their plans to vaccinate their child. So overall in the US at the time of this survey, half of parents said they either were vaccinated or planned to get vaccinated, and 22% of US parents said they would not get vaccinated themselves. When we look at how that relates to their plans for vaccinating their children, we see a very high concordance. So parents who are either vaccinated themselves or planned to get vaccinated, most of them, 85%, said that they would vaccinate their child. Among parents who said they would not get vaccinated themselves, most, 79%, this is the bar on the bottom, said they also would not vaccinate their child. And parents who were unsure were also unsure for their children. In New York City, we see essentially the same finding that at this time in March, many more New Yorkers either were vaccinated, or I should say New York parents were vaccinated or planned to get vaccinated. It was 67%, and only 9% of New York City parents in March of 2021 said they would not get vaccinated themselves. But again, we see that among parents who planned to get vaccinated or were vaccinated, most of them wanted to vaccinate their youngest child. And among parents who didn't plan to get vaccinated, most of them didn't plan to vaccinate their child. And the unsure parents were also somewhat unsure for their children. This is a more recent survey, so I wanted to end with this. This is excellent data from the Kaiser Family Foundation, which puts out fantastic COVID and other health-related news. This was a survey these were surveys that they conducted in July and September of 2021. They asked their questions slightly differently. So they were focused on kids 5 to 11 and younger. And they asked whether parents would get their child vaccinated right away, whether they would wait and see, only if required, or definitely not. And so, we see somewhat similar findings. Perhaps we're seeing that since July going into September, somewhat more parents will be willing to vaccinate right away, but we still have some vaccine hesitancy, some parents who want to wait and see, some who definitely will not vaccinate. Those numbers are very consistent with our findings, so that doesn't seem to be changing a lot. And we also see for children under 5 that there may be more vaccine hesitancy among parents of younger children under 5 years. So, Madhura, I'll turn it back to you for this slide.
Yeah. So, so vaccine hesitancy among parents is not new or unique to coronavirus. Although parents are more amenable to vaccinate their children with routine vaccinations such as measles or pertussis, a high proportion of parents are still hesitant to vaccinate their children against licensed vaccines such as influenza and HPV, or the human papillomavirus vaccine. The main barriers for vaccinations, which have been identified for these vaccines, are doubts about vaccine effectiveness, serious side effects, and novelty of the vaccine, especially for HPV. And these are some of the same barriers for vaccination that we see for coronavirus. Some approaches that have worked or might work to reduce hesitancy are, getting the vaccine at the pediatrician's office, or integrating it into routine childcare, where the vaccine is offered to children during their wellness visits, for instance. Presenting the vaccine as an opt-out or a presumptive approach, which means that the pediatrician, instead of asking, would you like to take the influenza vaccine, approaches it as your child is due for the influenza vaccine. And this kind of approach has been shown to make parents less hesitant to get their children vaccinated when the pediatrician pushes for the vaccine or uses this presumptive approach. School-based vaccination has been proven to be really useful to get adolescent vaccine uptake to go up, because it's easier for children to get vaccinated at schools, which takes the pressure off of the parents to take their children to clinics to get vaccinated. Reminder recall messaging has been shown to be really useful too, where parents get text messages or emails from schools or their pediatricians reminding them that their child is up for the next dose of the vaccine. And then finally, using social media such as Twitter and Facebook could be used to increase vaccine awareness and knowledge.
Great, so that we're sort of wrapping up, but we wanted to end by talking about what's coming next, and some of that's already been presented. So we know that vaccines are likely to be approved very soon, very, very soon, in the next 2 weeks or so for 5 to 11-year-olds. And we need to be thinking about strategies to ensure high uptake of vaccines for children in this age group. The White House, the Biden administration has released a plan about working with pediatricians' offices and also working with community leaders to try and combat misinformation and make sure the rollout goes smoothly for kids. It'll be important to think about how to target these the approaches to vaccination for kids in different ways, probably, than the way we did vaccination for adults. So it's very likely that offering them, as Medhara mentioned, through pediatricians' offices and schools, trusted venues where parents feel safe and feel like their child is already receiving services, may be a better venue or an additional venue that's needed, different from the sort of large-scale test vaccination sites that we saw for adults. We also need to do a lot around messaging to make sure that parents understand that, even though these vaccines may sound like they're new, there's lots of evidence and lots of information about mRNA vaccines, that they are safe, that's what the trials have been primarily focused on, is safety. And also, I think what our data show, and what's been, in comparing it to other vaccines, is trying to help parents understand the need to vaccinate children, because there's been a lot of confusing information, I would say, about the risk of COVID-19 to children, right? You sometimes hear, well, children aren't at risk, we don't have to worry about it for them, and then we see this huge spike in the summer. So I think that parents are probably confused about whether or not they need to do this, and whether or not their child is likely to get sick, and what that might mean, and weighing the benefits of the vaccine. So we need to be putting information out there to help parents make these decisions and feel confident in the information that they're being given. We also can't take our eye off the ball with vaccination coverage for adults and adolescents, because we're not going to be able to vaccinate very young children probably for quite some time. For small infants, we probably won't have a vaccine for infants less than 6 months. So we need to protect children in that way. But we also have a larger issue. For many of you, you may have seen the data that were released last week from an analysis that was published in Pediatrics, showing that at least 140,000 children in the United States have been orphaned because of the COVID-19 epidemic. That means they've lost either one or both of their parents. And this is devastating. I mean, this is a huge number of children who are going to face, significant challenges. They may be economic, they certainly will be emotional, and it's a huge toll. And so the more we can vaccinate adults and protect parents, we can make sure that they're around to take care of their children. So we can't lose sight of that vaccination campaign as well. And we already mentioned the vaccines for kids 2 to 5, hopefully will be available later in the fall, and maybe 6 months to 2 years by early next year. We wanted to thank certainly our institution, and especially for the funding for the work that we did. So this is the CUNY Institute for Implementation Science and Population Health, our co-authors and co-investigators on the work we presented, and obviously to thank all of the participants of our study in New York and in the US. And then these are just some resources. This is a very limited set of resources. These are great videos, this conversation about the COVID vaccine. That link has some really short videos about information about the vaccines and why you want to get your kid vaccinated, and questions about misinformation. Johns Hopkins also has great information for parents. And then the CDC has a fantastic website around geared towards pediatricians, but also other public health professionals around how to talk to parents about the COVID-19 vaccine for kids. All right, so we're done presenting, but we would love to hear from all of you. Any questions you have or comments about, vaccines for kids or our data?
I want to thank you both. This was extremely helpful in getting a better understanding of where we are and what we need to be doing next. I think the thing that jumped out to me most was the amount of children who have been orphaned due to the deaths of their parents. I don't think that we have talked about that enough or raised that. I see that there is in the chat, Dr. Nash, if you'd like to unmute yourself, you're more than welcome. Please feel free to make your comment.
Well, thank you so much, Deborah. I just wanted to thank both the speakers, Chloe and Medora, for a really excellent and informative session. And I think you have laid out all of the very complicated and interrelated issues very nicely and make the case for the need for some really prompt attention to this issue of vaccine hesitancy in children. Actually, the time was 6 months ago when you were starting, or more, when you were starting to do this research. So I do think there are so many opportunities to begin to get this. I don't want to say 100% right, because we've missed opportunities already, but there's opportunity to do better with children than we did with adults. Lots of lessons learned. Mm-hmm. You lay out a bunch of things that should be on the table for thinking about strategies to increase uptake. One thing that came to mind, I was also very moved by the statistic on orphaned kids. You know, it seems to me like there's opportunity to maybe address both adult and parental vaccine hesitancy by sort of saying, you know what, you both need to do this, because it seems like it's all going together. Mm-hmm. Parents who are unvaccinated are going to have kids who are unvaccinated. And I read recently a really nice editorial by Zeynep Tufekci in the Times, who, you know, always puts out nice editorials. She made the point that, you know, one of the things, people have become so entrenched around this issue that, but if you give them a mandate, that allows them to essentially save face and step up and get vaccinated if they're hesitant to begin with. But there may be other strategies that sort of give people an out to sort of step away from their sort of really strongly held position and say, you know what, this is time. Me and my kid can get vaccinated together. We can do it together.
And also making it more accessible. Vaccinating parents in pediatricians' offices is, I haven't heard, my sister's doing it, so I've heard about it from there, but I don't know how widely it's being done. But parents really trust pediatricians. And if they, you know, if they get themselves vaccinated, they're more likely to get their kids vaccinated. So as you say, they may want to do it together. So that's another strategy we should be looking at.
Anyway, thank you both. It's a great talk.
Thank you. Anyone else?
This is Edine. There was something that I'm missing in your presentation. The survey that you made that started in March 2021, how long did you run it for?
Oh, good question. Yeah, it took us, we ran it for about a month. So we were aiming for those sample sizes. So we ran it as long as it took to get all those samples, all the participants we needed. So in the US, it was about 3 weeks it took, and in New York, it took a little bit longer. So it was about a month. It was a little over a month. But it does just really capture that one point in time. And we can see from the Kaiser data that I showed you at the end, that's more recent, that, you know, there may be a little bit of shifting, but it does seem like there is this group of parents, around a quarter of parents, who feel pretty strongly that they don't want to vaccinate their younger children.
That's correct. Thank you for answering. Perhaps that's because in the beginning, because including me, I had to do some research to find out, because I do have children in my family. I'm not a mother myself, but there are children in my family. So I had to do some research in order to try and convince them. So before my research, I also was under the impression that children would not need it. Because in the beginning, everyone was saying, not the children, they were fine, they were fine. They don't even need to be masked. So that's probably what we should be we probably should let people know that, yes, we know we said that in the beginning. This is no longer the case.
I agree. I think, as I said, I think there is a lot of confusion about that, and interpreting, aggregate data and then making it more personal for yourself and assessing your own risk. It's very difficult to assess risk based on, how data are often reported. So I agree, we need to make it better, easier for people to understand.
Thank you. Was there another question?
I have a question, Mike Merson.
Yes, sir.
Chloe, very nice presentation. I have also an observation. One, my observation is I think using this kind of data would be very helpful in making the case. As you know, I think a lot about global vaccination rates, and the very low rates in Africa right now remain below 5%, many countries below 1% of the population. And one of the criticisms that have been leveled against the US, the G7 countries in particular, is that we shouldn't be vaccinating children because there's much more need for vaccines, particularly for Africa. So my observation is, I think the more you can make a case for vaccinating children to deflate some of that argument, because in fact, there's billions of doses available, and the reason why people aren't getting vaccinated in Africa is not related to vaccinating children or boosters. Unfortunately, that argument, as you know, is being used. So I would encourage you to use this data and even think about it in the global context. My question may be unfair, but if you were in a country in Africa, you worked in Africa, with less than 5% vaccination rates right now, how would you handle the question of vaccination of children? I'm sure the people are thinking about this who have access, the few right now that have access to vaccine. If you were, say, back in South Africa or any other country you worked in, maybe a hard question to answer, but something to think about, because certainly I'm getting asked that question myself. I don't know if you want to pass on it now or you want to comment, but it's just something to think about.
Absolutely. I think we should be thinking about all of those issues, the global issues, as well as our local issues. I think that, knowing what I know from working with you, I think that the issues with distribution in a lot of settings, including in a lot of African countries, it's less about having the doses and more about having the mechanisms for actually getting it into people's arms. And then from there, it will be a matter of trying to convince people of the need for it, especially since there's not been, as we know, the best surveillance in a lot of those settings. So people, as we are confused here about the risk to children, I think there's even wider risk, there's even bigger misunderstandings in other places about the dangers of COVID-19 and how at risk people are. So I think that if it really were an issue of dosing, of having enough doses to dose children, and if we really did have to make that choice, as a parent, I think that I would feel okay about not vaccinating my kids for a little while to give the doses to people who really need it. But I'm not sure that that's really that's not what's driving this. I could be wrong about that, but I think that, hopefully by the end of the year, we'll have enough doses for everyone, almost everyone in the world. And we certainly have adult doses in this country that we could be, that aren't being used. So we should be donating more of those.
Thank you. Was there another question, comment?
Yes. Hi, I unmuted myself. My name is Anthony Carrion. I work with Hunger Free NYC, an anti-hunger, anti-poverty organization. We're conducting a COVID-19 outreach program currently, and we help enroll many families into the SNAP and WIC program. So we're in contact with many parent-teacher associations, and school groups, community groups. And what we've heard from some of our initial meetings from parents was that they were the group that we spoke with was adamantly opposed, and for a couple of reasons that I think, that presentation might highlight some of those concerns. One, I'll name two. I think one would be the truncated clinical trial period. This concerns parents in particular because children are still developing, right? So truncating from 5 to 15 years, which is the typical clinical trial, to 1 to 2 years, and having those phases overlap is disconcerting for many parents. The second point is that in your presentation, I think you pointed out that these trials, their end date was, in later this year, 2022, 2023, 2024, and the approvals are going to be coming later this month, perhaps early next month. And so that, I would like those two specific points addressed, because I think the parents are really concerned, like you said, about the safety, making sure no steps have been missed. And it's hard to convey that argument when the timeline is so truncated. And so that's the first question, those two concerns. And the second question would be related to the risk that you spoke about. Of those deaths that have occurred, were those in healthy children, or did the children have underlying medical conditions that made them succumb to the coronavirus? Thank you.
So Maher, I'll start, and then you can, if you want to answer the trial question.
Yeah, sure.
In terms of the EBI question around the deaths in children, similar to adults, it's been very mixed and surprising. So a lot of deaths in children have occurred. The almost 600 deaths that have occurred in US children since the start of the epidemic. Some of those deaths have been in children who had underlying conditions or were immunocompromised. A lot of them happened in perfectly healthy children who we never would have expected to succumb to COVID-19. So the unpredictability of COVID-19 as a parent is terrifying, because you just don't know what's going to happen if your child gets infected. And the likelihood that something serious is going to happen is not high, but you can't be sure of that. So I guess the argument I would make is, why wouldn't you want to vaccinate your child so that you then really don't have to worry about your child experiencing severe disease or experiencing problems later in life, respiratory problems, whatever may be identified, if anything, in terms of long-term health consequences of COVID-19 infection. Again, we know other viral infections that happen at critical points in development or during childhood can have lifelong effects on children's health. And so we don't know yet whether that is true for COVID-19, but we have, there's reason for concern, and there will be more study of that. So that's in terms of the risk. If you look at the risk profile of the children who died, it really is heterogeneous. It really is variable. There are perfectly healthy children who died from COVID-19.
I can address the trial questions. First, about the truncated period of the clinical trials for both adults and children. So like I mentioned before, that the trial period is truncated, but they're not missing any of the crucial steps. They do phase 1, phase 2, phase 3. They follow all the good manufacturing practices and the safety assessments and the adverse events assessment. There are no it's not short-circuited there. So the clinical trials are done by the book. The truncation happens when they have sufficient data to decide that the vaccine is indeed safe. The vaccine manufacturer can go to the FDA and present the safety data, and then the FDA can take a call on whether these data are sufficient for the vaccine, for an emergency use approval. So there really is definitely a very tight regulation process there. It's just that it's done over a short period of time. And FDA also weighs the risks with the benefits of the vaccine, right? So if you have an ongoing public health emergency where people are dying in huge numbers, and you have a vaccine that is shown to be safe and effective, but those results came in like a few months, a period of like 6 or 7 months, the FDA can take these kind of decisions where they have now decided that the risk of having COVID go on for 2 years is much higher than having a vaccine that is safe and is effective and has been produced with good manufacturing practices, can prevent infection and save lives. They will grant it emergency use authorization. Secondly, just because a vaccine has EUA doesn't mean that the manufacturers can stop the process. They have to still conduct the trials, bring them to completion, and present the data to the FDA if the vaccine, if they find some issues with the vaccine during the clinical trials, they are bound to report it to the FDA. It's a very transparent process. So I feel like parents should feel I think as public, we should trust the process, especially in the US, it has been pretty transparent. And we could, I feel like, personally, I feel like we could have truncated time periods for other life-saving vaccines and drugs, but you need the political will and the funding for these kind of regulatory processes. The second point was about the trial end dates, and then having these, the trials are ongoing in the background, and you already have the vaccine in the field. Like I said before, the vaccine manufacturers are bound to complete these trials and present the data of the completed trials to the FDA and to the public. Usually, safety, whether the vaccine is safe or not, this question can be answered pretty quickly in a trial, in the earliest stages of the trial, especially in phase 1 and phase 2. Those are particularly focused on safety of the vaccine, and any adverse events that happen within a month of completing the vaccine dose, or a month or 2, get reported as vaccine-related safety issues. So these data can be collected early in the trial and presented to the FDA early. And once they see once they have like enough number of people in the trials that have been followed for a long enough period, and they see very few adverse events, the FDA feels comfortable releasing the data, releasing the vaccine, licensing it through EUA. However, you need to follow people for a longer period of time to make sure that the vaccine is actually efficacious, because infections may happen over a longer period of time. Right? So for the vaccine manufacturers to say that my vaccine is effective 6 months down the line, 12 months down the line, 18 months down the line, you have to actually follow people up for that time period, but you cannot hold back a vaccine that is safe and produces good antibody titers for 2 years. So that's why you have things like EUA in place. So in the background, they're still following people up over time. They will follow them up till 2023, 2024, and they can then comment about the effectiveness of the vaccines over a long period of time, if there are any waning effects of the vaccine, etc.
I think that's a good point to make to parents who are vaccine hesitant. I think we have to listen to them and understand their concerns, but explaining that the trials are going on not because of safety issues as much as for efficacy, for understanding that, as Dr. Reen's saying, over the course of the epidemic, that we've seen changing dynamics, right? We're dealing with a surge in kids, and it's now coming down. So we want to be able to measure that. So it's much more about the effectiveness and efficacy of the vaccine. Vaccines would not get emergency use authorization if they weren't safe.
Correct, exactly. And another small point that I want to make, that we could which can be used to relay this information about vaccine safety to parents, is to look at real world data, right? There are a lot of real world vaccine effectiveness studies that are happening for adults and will happen in children once they start to get vaccinated, where these are not clinical trials. You're taking data from people, who are, these people are not part of clinical trial. You measure the vaccine effectiveness in a real life situation, like in a field situation, and you can actually see that the vaccines are safe. There have been very few adverse events in adults, which are not outside the ordinary, not statistically improbable. So these kind of real world studies really, they give credence to the randomized controlled trial processes, which are really done under an experimental situation. So yeah, we need more of these real world studies, and we can use data from these studies to convince parents that the vaccine is indeed safe, even in a real world situation.
Abigail, I know you've had your hand up for a while.
Yes.
I was hoping to ask a question about more the adolescent group, because that's the age range that I work with, and particularly like the age of consent for vaccines. And I'm noticing that in some states it's maybe 16, whereas in others 18. And if you've seen any uptick in like, okay, maybe it's the parental consent that's holding adolescents back. So for those states that have lower age of consent, and also kind of more of a policy question there, if there's any push to allow students to consent. And I specifically work with kids in foster care, which holds them back even more with getting biological parent consent. So anything in that area.
So I am not an expert on that area. I have read a little bit about it, and as you say, it does vary by state, the age of consent and whether children can get vaccinated against their parents' wishes. And there was an article, I can send it to you. It was, I think, in Pediatrics or JAMA Pediatrics, and it was about, it was written by pediatricians advocating for sort of the age of 14 for different sort of developmental and intellectual reasons being the age at which children that might be an appropriate age at which children should be able to make their own medical decisions. But they were putting forth that argument rather than saying that that's how it is. So that may be a barrier for some adolescents getting vaccinated. I've seen some stories about that. I don't know how, to what extent that's a major issue. But it's interesting, and I don't have a lot of information on it, but certainly something to keep track of.
I would like to add a little bit to that. Self-consenting, allowing adolescents to self-consent has shown to work for the HPV vaccine, and especially if these vaccines are available in school clinics. Then adolescents they have a safe space to go and get these vaccines if they feel like their parents are not on board and they want to protect themselves against COVID. So this is definitely, I feel like it's a very interesting area for policymakers to focus on as we start to think about increasing uptake for adolescents.
Thank you, Dr. Nash.
Thanks. Okay, these are really interesting discussion points. And I think what you guys are saying about vaccines, I mean, first of all, like while there may be concerns about risks of getting vaccinated, there are also concerns about the adverse effects of the virus itself, right? The virus itself can cause damage to developing organs and fully developed organs. With vaccines, adverse events, my sense that is I think what you guys are saying, which is my sense too, which is they tend to be on the short-term side, not longer-term side. And so, if they are common and if they are severe, they tend to be identified pretty quickly and within the timeframes of some of these trials, which is great. I just wanted to return to this idea and thinking about, like, there are individual reasons why parents and kids may decide to move forward with vaccination or not. And I wonder if there's room for appealing to some of the societal ones as well. I think you've touched on some of them, but my sense is from the limited modeling studies is that kids contribute a lot to transmission of COVID, and that if we can reduce transmission of COVID among kids, then it will also have an effect on reducing transmission of COVID among adults, which is driving most of the deaths and hospitalizations. Kids, my sense, almost 0.5% of all kids living in the US have been hospitalized with COVID, based on a study of 14 states, which works out to be about like 400,000 hospitalizations. I know not some of them are hospitalizations where providers are being on the cautious side, making sure that nothing serious is going on, but a significant proportion of them involve, invasive mechanical ventilation, like upwards of 15 to 25%. And the last thing is I think a lot of our teachers and educators and are really anxious, even though they may be vaccinated themselves, having to be in the classroom with a bunch of unvaccinated kids, sometimes unmasked kids, depending on where you live. I think this is another big reason to put on the table for why childhood vaccination is important for COVID.
It would be interesting to see how mandates go for schools. I've already heard from some New York City schools, some private schools are mandating vaccines for children who are eligible now. So we'll see if that happens for younger kids as well.
And to quickly add to Dennis's point about transmission, like kids not getting sick, but still, transmitting to older adults, we have to also think of what happens if the virus mutates to a form, which is now more dangerous among kids and causes more severe disease among children also. So that is another reason where we need to exercise caution and can be used to explain to parents why it is necessary to vaccinate kids, not to just protect themselves, but to reduce transmission and prevent the strain mutating to a more dangerous form. We've already seen that with Delta, and there's just no telling what's going to happen.
Any other questions, comments?
One last comment that I'd like to make. I particularly was interested and I really appreciated the part of your presentation that dealt with the mRNA. I learned a lot. That was great. But if I believe your survey and also the survey from the Kaiser Foundation, parents are saying that safety is their primary concern. If we take them at their word, then I think that part of that presentation was really the meat of the matter, is to let people know about the safety of the vaccine. Because if I had a penny every time I heard someone say, but it was developed so quickly, how do we know to trust it? Those vaccines take years and this one takes literally 2 minutes. So how do we trust it? So I think we should, wherever we go, emphasize that part, the safety of the vaccine. We know that millions of people all over the world have taken it, but that seems to not matter to people who don't trust it. So perhaps if we explain, just like you two just did right now, and you did an excellent job of explaining what mRNA is, what the trial is, what the development is, why it was so quick, and what the difference is between full approval and EUA and so on. That, I think that might assuage some people's fears. I know for a fact that I'm going to, if I can get a hold of that presentation, that's something that I will share with my coworkers and definitely with my own family members to tell them this is it. This is the data. There is nothing mysterious about it. This was not something that a psychic developed. It's real data based on science, and we should emphasize that. If really their fears is safety.
I think those are great points. And yeah, absolutely. And yeah, please do share the presentation. It'll be available in different ways. Talking about safety. And also, I think sometimes when people just have a space to talk about those safety issues and just be heard, for some people, that's enough. It's just expressing those concerns and then getting some more information, and hopefully also, as you know, the first wave of parents get their kids vaccinated, other parents will see, okay, that makes me feel safer. And so that's the hope, right? That people will, you know, see their friends doing it and feel like, okay, if that person's doing it, maybe I can feel okay about it too. But sharing information is also going to be really critical.
Great. Thank you for that question and comment. I think we did our job. If you are willing to share that information with your loved ones and your coworkers, then this presentation has done its job. And so I want to just make sure that if there are any other comments, questions, anything else that anyone would like to raise. Seeing none, I would like to thank you both. This has been a phenomenal presentation. Every time I hear more information, it gives us more opportunity to share. And so I really want to thank you for taking the time. Dr. Nash, thank you for dropping in and giving us your pearls of wisdom today. We really appreciate that. I see that Hannah Lathan is on here from the New York Vaccine Literacy Project. Please reach out to her also. She has great resources, and we're happy to share those. Seeing that there are no other questions, we want to thank everyone for their time, their energy, their talents, but most of all for the work that you do. We know that this has been an extremely difficult 2 years, and there is light at the end of the tunnel. So please keep educating, please keep sharing. We will be sending out the link for this. It is also on our Facebook page, and we'll also be sharing with you the links for our upcoming webinar series. It is also in the chat. So once again, thank you all very, very much and appreciate your time and energy.
Thank you.
Thank you all.
Thank you. Great job.
Thanks. Take care.